morning. I would like to thank the organizing committee of West Bengal Pediatric Rheumatology Society for inviting me to chair this session. Now this topic is it's a panel discussion on infection and inflammation and hyperinflammation, infection and hyperinflammation. Our moderator of this panel discussion is Dr. Priyankar Pal. Please come on stage. Dr. Priyankar Pal is head of the Department of Pediatrics at Institute of Child Health, Kolkata. And he's a consultant pediatric rheumatologist. Everyone knows him. He has many publications to his credit. And now I would like Dr. Priyankar Pal to introduce the panelists.
So I think the stage has been set by a previous presentation by Dr. Maria. I would request the four panelists to come and join me over here. So we have Dr. Madhumita Nondi. So Dr. Madhumita is HOD Pediatrics at the North Bengal Medical College. So she is a pediatrician with an immense interest in pediatric rheumatology. We have the infectious disease specialist, Dr. Jogiraj Rai, who is an associate professor of the Department of Infectious Disease, IPGMR, Kolkata. We have the pediatric intensivist, Dr. Kaushik Mollik, who is a consultant pediatric intensivist at the Apollo Multispeciality Hospital, Kolkata, and an assistant professor at the PICO of the Institute of Child Health, Kolkata. And we have our own Dr. Vijay Vishwanathan, the rheumatologist, who is a consultant pediatric rheumatologist from Jupiter Hospital, Thane, and Apollo Children's, Navi Mumbai. So let us have an inflamed session, I think. So we have the whole team over here. So just over here. So as you can see, that sepsis is just not sepsis. It's basically a dysregulated host response to an infection. Right to left. So if you look at the cytokine release syndrome, it's a webinar that happens every yearly. So I think about 2 years back, this was a person who was speaking from US. He's an intensivist, and he gave that of the 5 million ICU admissions per year, 4 million experience a cytokine storm. So it is not uncommon. So the infection and hypercytokinemia, we know about it from the late 70s when there was a paper by Dr. Nesbitt, viral associated hemophagocytic syndrome. This was followed by the FHL, the familial histiocytosis study group, Professor Hunter and his colleagues who published extensively on familial HLH. Professor Grita Janka, who published on infection and malignancy associated hemophagocytic syndromes. So this is going on since the late 70s. And you have the HLH 2004 criteria, which actually was basically dealing with more of a primary hemophagocytic lymphohistiocytosis. But over here, we are interested more in the secondary one. And this was one of our old publications, I think 2011, when we published a series of 23 cases of infection-associated HLH, which we treated only with steroids. So you can see there was hepatitis A, chikungunya, tuberculosis, CMV, dengue, EBV, so a whole gamut. We did not follow the entire protocol. We just treated with steroids. I think the timer is not moving. Can you have a look at the timer? And it was around 10 years back when this name came up, the cytokine release syndrome, which came up in association with CAR T cell therapies, and the hyperinflammation followed that, and there was a cytokine storm syndrome. There's a beautiful book by Professor Randy Cron. You can go through this book if you're interested. So cytokine storm refers to a diverse set of conditions with the shared clinical phenotype of hyperinflammation, the hallmark hyperferritinemia, and a multi-organ dysfunction, which results from excessive cytokine production through unchecked and amplified immune activation. And there's a huge host of conditions which can actually trigger this. You can have a genetic basis, which is a primary HLH, a lot of infections, oncologic, leukemia, rheumatic, MAS in association with SJIA, medication, and iatrogenic. So the list is exhaustive. So let us look at the changing times of 2020-21, when actually the world became a little more aware of the cytokine storm syndromes. So this is a very interesting thing, that the multifaceted immunology of cytokine storm. So they have reflected there's nothing quite as powerful as a worldwide fatal pandemic to bring increased attention to cytokine storm syndrome. And from a lumpus perspective, CSSs have garnered attention from a vast variety of biomedical disciplines. So people were talking about cytokine storms in general. So I'll start off with the infectious disease specialist. So Jogiraj was actually deeply involved in COVID during the COVID years. So what was your perspective of a cytokine storm syndrome in the COVID-associated cytokine storm?
When I started seeing COVID patients, the first COVID patient of Bengal was my patient. So from that, at that time, the notion internationally was not to give steroid because it is a viral infection, as we have a vast experience of influenza where we don't give steroid in ARDS also. So in that perspective, we avoided steroid in initial few patients, but with 1 or 2 months, when real COVID patients that with hypoxia started coming, we quote unquote we started giving steroid with hypotensive patients with hydrocortisone, as we give in hypotension in shock, and these patients was favored better than others. So that in that 2 to 3 months interval of first patient to our faith on steroid started with giving hydrocortisone. Then there was evidence that steroid actually saving lives. So that there was paradigm shift of giving steroids from anti-steroid to pro-steroid. Then again, what started giving long steroid. That even was very risky, and lot of patients actually developed sepsis after that. So there was a requirement of judgment over there. But with time, there are a lot of biologics also came into play. People was running after biologics. And at that time, I got an opportunity to work with one immunologist, and we published a lot of paper with him. He's my senior, Dr. Dipoman Ganguly, you may know him. Later, he got the Bhatnagar Award for his work in COVID. So we started seeing with a trial, we went for 80 patients with severe COVID and 80 patients with without severe COVID. So we followed them up for 10 to 15 days of their hospital stay and like that. So what we found that there are vast difference in different patients. So there are different subsets, and all subsets are not same. Some of them have expression of high amount of soluble urokinase, and these patients are actually having pulmonary hemorrhage. So in that patients, we pulmonary thrombosis. So in that patients, we have given say anticoagulant, and but majority of the patient had high CRP, high inflammatory markers, so and hypoxia simultaneously. So steroid was better for them, but some patients, only a few, had interleukin 6 level high. So there are subsets, and there must be some host pathogen interaction as plural as HLH spectrum. So we have to actually identify different pathway, which pathway is activated in whom, and actually what should be the immune suppression in all them, not steroid for long duration. So that was our experience.
So if I sum up what Jogiraj said, that here was an infection, a viral infection, a global pandemic, where immunotherapy was making a difference. But the timing of the immunotherapy was important. I think it was working best in patients who were developing hypoxia. So not too early, not too late. And again, the duration of the immunotherapy, not too long. So that was basically the game which was being going on. And if you look at the recovery protocol, you can see what made a difference: steroids and subsequently baricitinib. And this was the landmark paper that was published in NEGM, dexamethasone in hospitalized patients, tocilizumab was tried. So yes, for the first time possibly, everyone was talking of immunotherapy in the background of an infection. Now let us look at the pediatric subset during that time. So July 2020, lockdown is going on, and we have this 6-year-old girl with fever, loose stool, red eyes, rashes. You can look at the rashes involving the palms and the palms. And day 5 of illness, she has a sudden onset hypotension. So I would request Dr. Mothumita Nondi, the pediatrician, how would you have investigated and what can be the possible diagnosis?
Possible diagnosis, obviously, we are sitting in a panel discussing cytokine storm. It has to be something related to that. But on a serious note, if you think of the etiological possibilities broadly, I'll put etiology into 3 broad headings. Like, is it directly something infectious etiology, or it's not a result of some post-infective related to immunological phenomena related to some infections? And third possibility is non-infective, just inflammatory etiologies. No infections identified. So infection is dengue and all things. Yeah, we have
so
rash,
you are passing
fever.
through lockdown. Everyone is at home.
Yes, that's what I'm coming to. So infectious etiology, dengue-related virus complicated by dengue complications, that is a possibility. Non-infectious Kawasaki is a possibility. But in view of 2 or 3 things, as you said, the timeline, the temporal relation with lockdown and COVID and pandemic
it's July
and other
2020.
things. So is it related to COVID? Number 2 is for Kawasaki may very closely mimic post-COVID that MISC, but age is 6 years. So Kawasaki mostly, it's not that it will not occur in a 6-year-old child, but it's more common in
so what do
age
you
group
think
of,
has happened to this child? So this child has come under day 5 of illness with a sudden onset hypotension.
Yes. So it's some complication of some infectious pathology, what I feel.
So what was happening on those years?
And looking at the temporal relation, I will think of MISC as my first
Yes.
possibility.
So that was something that was going on. I think it was first reported in Europe, and then because of the webinars of that time that was going on.
At that time, July, 1 or 2 cases were coming up, some descriptions, some case reports were coming up. But,
so how would you have investigated this child?
I would have, if the child has come to me for the first time without any previous.
This child has come in shock, hypotension.
Yes. So I will first obviously give symptomatic management of shock with fluids and other things. And then I will try to make an etiological diagnosis. Etiology related to infections, so all possible
So I think it's the intensivist domain now. So this child has landed in the intensive care. Kaushik, tell us something.
So when we encountered these patients, what we used to find is that they are sometimes acutely crashing and presenting. And when we put the echo probe, which we often do in our ICUs right now, because ultrasound machine is readily available, we find severe myocardial dysfunction. So per se, it's a cardiogenic shock that we get. And another typical feature we find in this patient is that when we put the arterial line, and obviously to monitor the continuous blood pressure, there is this wide pulse pressure. So typically in cardiogenic shock, we should be getting a narrow pulse pressure. But in these patients, so there used to be a significant component of vasoplegia also. So they used to have diastolics even which has gone down to 30. And systolic also was low, but it was not that low. So we used to get a wide pulse pressure. So for these patients, we used to do the echocardiography, send the inflammatory markers like we used to send ferritin, D-dimer, fibrinogen. Anti-COVID antibodies used to be sent at that time because at that time COVID vaccination had not.
What was the CRP like in these
And
patients?
CRP used to be sky high.
Sky high, almost
very,
150,
very high
200,
CRP.
250, something
Yes,
like that.
so it used to be 50, 60 times, sometimes 100 times elevated. And then we used to obviously give the symptomatic management and immunotherapy. And immunotherapy used to work like wonders in these patients. And a time had come when, as Madam mentioned clearly, that infection-related complications, when the wave of MISC came, with a single glance at the patient, we could tell, yes, this is MISC. So we almost had no other differentials at that point of time for quite a significant period of time. So many patients. And they also used to have that conjunctivitis typical, that bulbar.
We showed the red eyes.
conjunctivitis.
The red eyes,
Red
yeah.
eyes it used to.
Non-purulent bulbar conjunctivitis, like KD.
Yes, absolutely.
So, Vijay, would you summarize your experience with MISC?
So I thought if I sit here, I'll get the first chance. But even in life, the rheumatologist is often blessed or cursed to be called.
No, intensivist has called you now.
At
Just
the very end, yeah. But jokes apart, this used to be a very straightforward thing once we started following the trend. And I always believe in the A, B, C, D, E, F approach for MISC. So most of these kids would come with A for abdominal pain, B for blood-tinged eyes, C for cold, clammy extremities, D for diarrhea, abdominal pain. Typically, the adolescents who have abdominal pain would not be rushed to the pediatrician also. E for extreme fatigability, and F for persistent fever. And day 4, day 5, day 6, they used to just come crashing with hypotension. And that always used to give a clues. Again, what are the blood tests that the pediatrician should think? A for albumin antibodies, maybe a PCR or an antibodies. B for BNP, so N-terminal pro-BNP used to come to our rescue, at least being a sensitive but not specific marker. We have seen BNPs really high, 70, 80 thousands. C for CRP, coagulation disturbances, cultures, and creatinine. I always used to send D-dimers because it kind of pointed to a coagulopathy. E for enzymes, and then because you know that the kidneys also were affected, I always used to send a urine PC ratio. The bottom line is, the term that I found very useful to explain it to myself and the pediatrician was inflammatory coagulopathy, resulting in multi-organ dysfunction. So when you have features suggestive of Kawasaki disease with any organ involvement in the form of liver, kidney, GIT, and the CNS, with coagulopathy, which is inflammatory. So high CRPs, high ferritin. Many of them would actually have slightly deranged ferritins, not really very high, but overtones of HLH, as we would call it. So end of the day, when people said, "Kya ho raha hai?" I used to say, don't forget everything, it's Kawasaki. It may not be Kawasaki, but what follows a COVID infection looks like a Kawasaki disease shock syndrome. It's the easiest way to understand. Think of, nobody will diagnose MISC, I think, right now in July 2025, but this was the way I used to dissect it out.
And what about the procals in those patients, if you remember? The procalcitonins?
So, in fact, the lesson that all of us should learn is high CRP doesn't mean infection, because like Priyanka and our intensivist friend said, we used to see a lot of CRPs in MISC, and what would you do? Not step up the meropenem and vancomycin. You used to pulse them with steroid, immunosuppress them. So I am almost convinced that the higher the procalcitonin, higher the CRP, you may be looking at a hyperinflammation story. And it's always a story of, like we will discuss hopefully, that think of a infection, rule out a malignancy, and start addressing the cytokine storm. High procal doesn't mean infection alone. High CRP doesn't mean infection alone. it has to be taken in the context of the clinical scenario.
There's one point I'd like to mention in this context, like from intensive care point of view. This is the subset of cardiogenic shock patients whom we treated with milrinone plus norepinephrine. Why? Because this is a subset of patients with cardiogenic shock who had very prominent vasoplasia, as I mentioned. So they required a lot of norepinephrine and even vasopressin, which is quite uncommon. When we were managing them, we had found at that point of time.
So have a look at this umbrella by Dr. Scott Kana. So this is the umbrella of the cytokine storm. So we have a lot of terminologies, the HLH, the MAS, the CRS. So it is a unifying umbrella. If you look at the umbrella, so there's infection which comes in, there's viral associated CSS which comes in. So you have flu, COVID, MISC, KD, you have malignancy associated CSS, and you have the SGIMS. So everything, you have a unified sort of umbrella approach if you look at if you call it a cytokine storm syndrome. Let us go over to another case. So this is a 9-year-old fever. So this is just a new, very latest patient, last month on 16th on oral antibiotics. So 8th day of fever, the child is drowsy, Vidal is strongly positive, the blood culture gives salmonella, and if you look at the reports, so look at the reports on 24th and 22nd. Jogiraj, how would you like to interpret these reports? So you can see that the platelet is coming down, your CRP is very high, albumin is low, and OTPT is deranged.
So this is a involvement of multi-system due to inflammatory response to typhoid. I will like to see like that. And one point in CRP, we don't give much importance in CRP, in all ID. We don't give much importance in CRP. We just see the patient clinically. That is the most important CRP for us.
Okay.
Yeah, I will give more importance to this trend of counts. Known typhoid is already diagnosed. As typhoid, salmonella typhoid, you are saying it's diagnosed, but the child is not becoming better. Child getting sick and the counts, this is very important, and the counts decreasing. So
would you like to have a look at the HLH parameters, the ferritin?
Yes, of course I'll like to
would you like to
look.
have that? And would you start immunotherapy or would you like to wait?
I'll of course do investigations for HLH, I mean your mass or HLH parameters.
So if your ferritin is 12,000.
Yes, if ferritin is 12,000, if triglycerides are more, if fibrinogen is less, and here a differentiating point is ESR. We give, because as I work in a government hospital in a so-called periphery in North Bengal, where all these detailed investigation facilities are not always available, but ESR, a child getting sick, decreasing count, ESR not that raised. Suppose, have you shown ESR? Actually, if in this child, if ESR is still 10 or 12, I will think of, because we don't always get facilities for ferritin, aaj hai to kal nahi ho sakta hai. So, to save, actually, picking up these patients in time is important.
So, my question would be to Kaushik. So, would you like to start immunotherapy or would you give antibiotics or observe the patient, knowing that there may be an underlying cytokine storm?
Yes, sir. So,
short answer.
In this situation, I would have to like to have some basic investigation. So, what is available to me that I would like to know?
Your ferritin is raised. So, the HLH parameters are raised. Yes. You have started antibiotics. The patient is drowsy. Would you start steroids or would you like to observe the patient?
At this point of time, with only a raised ferritin is there, along with that my counts and platelets both are dropping. So I think that giving 1 or 2 doses of steroids may not cause harm, and just seeing what is my response with that.
I would want you to tell me that the ferritin is 1200 and not 12,000. 12,000 is a no-brainer. This is frank HLH. You would want to pulse this child as hard as possible, but 1200 is with a backdrop of a known etiology. You may serially monitor, watch for, treat the infection. Maybe the HLH will get better like nephrotic. And then
so you have a bacterial infection, the HLH may improve on treatment, If the patient is worsening, you start immunotherapy.
Sir, for just one more thing in this aspect, like in these situations when we have a borderline ferritin, like we do not take the 500 cutoff obviously. Like for example, if we have a 7,000, 8,000 ferritin, we usually in the clinical context also give importance to fibrinogen. Like if we find that my fibrinogen is low, especially around 100 or even below that, then we are quite sure this is probably HLH that is going on.
Definitely.
So then our
And a
decision
ferritin
becomes
above
easier.
10,000 is almost
Is,
HLH.
Yes, yes.
It has a 96% specificity for HLH. I think I have a slide of that.
One last thing is always do an ESR when you do a CRP. ESR is the poor man's fibrinogen like we know. And that discrepant ESR and CRP, you can't compare yesterday's ESR with today's CRP with tomorrow's ferritin. Either you do all of them at the same time, but ESR is like kadi patta, you know. How many of you know how much 100 grams of curry leaves costs? Even the pathologist is not interested in doing ESRs these days. I'm talking of Mumbai. So it's not non-specific, but please do it in these situations.
Okay. So moving on to the adenovirus. So we know, I think everyone experienced over the last couple of years, a lot of cytokine storms associated with adenovirus. Even if I do not say cytokine storms, bad adenoviral pneumonias. So let us look at this baby. I think this is the same baby Maria presented. So this is an 11-month-old baby, fever, cough for 5 days. And these were the initial investigations. And this is the X-ray you can see, some patchy opacities, interstitial. Day 3 of admission, so this is day 8 of illness. The child is still febrile, looks a bit lethargic, and respiratory PCR shows adenovirus. Day 5 of admission, so that is day 10 of illness, the spiking high temperature, 105 degrees. Now the baby is not only lethargic, the baby is drowsy, there's desaturation, the baby is transferred to the PICU, and you have the reports, you can see that counts are coming down. There's a serial fall in counts, the platelets are coming down, the CRP is normal, but albumin has come down, there is transaminitis, significant transaminitis, the SGOT is more than 10,000. So would you like to do some more tests? Anyone?
Yeah, again, it's a similar situation. That was on post-typhoid, and this is post-adenovirus. So child not improving, rather getting more sick with declining counts, with transaminitis, with albumin low. Definitely investigations
so
for
this is
HLH
almost
or
like an
MAS
algorithm.
are required.
So a child who is not improving, maybe the fever pattern has changed, there's development of multi-system involvement, this child has become encephalopathic drowsy, there's hepatopathy, the transaminitis have gone up, the platelets are coming down, the counts are coming down, the neutrophil lymphocyte ratios are getting altered, the CRP may not be elevated.
Yes,
So
but here also I would like to know about ESR. As Dr. Vijay said, ESR nobody talks about nowadays, but ESR still has
Vijay, would you like to say why the CRP is not elevated in a lot of viral infections?
Because it's never done. So in isolation, the ESR and CRP doesn't help probably, but the minute you start combining the two, again in this situation, this child has almost, he needs a liver transplant sooner than later. 11,000 SGOT PT, you know that you are entering the HLH MAS territory. I would like to call it Hamas, you know, forget HLH or MAS, it is Hamas, it is angry inflammation. You will do what needs to be done. And again, one of the situation, don't go on CRP alone. I have read enough about dengue and CRP.
We'll come to that.
Yeah, means why the CRP doesn't go up. Don't say CRP is not very high, so it's not HLH. There are probable mechanisms which maybe the interferons which are released in fighting the infection doesn't allow the CRP to mount, possibly, but it's always taken to be together.
So basically what was he was saying that the CRP is IL-6 driven, but it may not be IL-6 driven, the inflammation may be IL-1, IL-18 driven. So that time the ferritin goes up, but the CRP doesn't go up. So over here, you have a significantly high ferritin, 15,000. So Kaushik, I think you are involved in this patient. How did you intervene?
So yes, I was involved, and as we saw that the counts were dropping, the platelets were dropping, hepatopathy was there, ferritin was above 10,000 and sky high. So we naturally knew that this patient is going into HLH along with the clinical presentation. So we started the child on immunotherapy. We started initially on steroids. And
Dose of steroids?
10 mg per meter square per day of
Dexa.
dexamethasone. That's what was started.
So the next day morning, the baby is afebrile, on nasal cannula oxygen, no further deterioration. Kaushik goes for evening rounds and he gave me a ring. So this is the evening round, sudden increase in the respiratory efforts, and the X-ray has been done. You can see there's worsening. Your thoughts?
Yes, so by this time the kid had already received immunosuppression for some time, and as we can see from the serial trends of the investigations, the inflammatory markers had started coming down. Ferritin had come down from 16,000 to around 8,000. The encephalopathy had also improved. The counts had started improving. Platelets had started improving, and liver enzymes had started falling. So overall, the inflammation seemed to be improving. And by this point of time, I think the child had received 10 mg per meter square per day dexamethasone for quite a few days, and also probably anakinra, right,
No,
sir?
anakinra.
Or
Just
only
Dex,
dexamethasone,
just Dex,
right?
sir.
And then we found that the child was having respiratory distress, and on auscultation there was crepitations, and chest X-ray revealed this picture. So naturally I felt at that point of time that probably now the child has developed a secondary infection, probably a pneumonia. So that's why I called sir, and I felt that we should.
Or there's a adenovirus is flaring only.
And also it is possible that the adenovirus might be flaring, because the primary thing might be flaring now and the HLH might be settling. Also it could be a secondary bacterial infection, any other thing. So we again sent the cultures, markers, and we started on appropriate antibiotics, and also we felt that probably adenovirus might be worsening, so this child might require cidofovir injection to control the worsening pneumonia, and we came down on the steroid dose significantly. I think we had stopped at that point of time or lowered the dose.
So that is the thing, that these are all dynamic patients. So every day you have to take a decision regarding the patients. And again, the dose of steroids may not be uniform for all patients. And what we usually do, we give a very short course of steroids, 5 to 7 days. Maybe after 48 hours, if the child is improving, we start coming down of the dose, maybe within 48 or 72 hours. So what we said, ferritin levels about 10,000, almost 96% specific for HLH. I think I will just, because of lack of time, I've thought I'll ask Jogiraj. So this was our experience for adenovirus CSS. I will again just skip. So what we came across, that it was not at the initiation, it was almost around 7 to 10 days of the infection that the patient developed a cytokine storm syndrome. And this was our Shuparna's paper from her institute. And this was another patient who had severe adenovirus pneumonia with aneurysms in the coronary artery and ultimately received anakinra. This was also published. So the final thing, does viral hemorrhagic fever represent a reactive hemophagocytic syndrome? Because that is one thing which is a nightmare. Dengue remains a nightmare. So this was a very old case series that we published, the dengue associated classical. This was HLH. So we were not aware about CSS at that time. Let us look at this patient. This is a 14-year-old girl, diagnosed dengue, admitted. We'll have a very short sort of rapid-fire round of questions because we don't have much time. Admitted on day 7, hypovolemic shock. So initial management we all know. So we have given crystalloids, we have given colloids. So I will just skip over that. So the patient is in the ICU, and these are the investigations now. So you have a platelet count which is of course 15,000 dengue. The creat is 0.9. The OTPTs are again very high, and the ferritin is 1 lakh. The fibrinogen is low. Vijay, would you like to modify your management? Would you like to think of something else?
So this is, again, no-brainer. This is call it macrophage activation syndrome, call it HLH, call it HLH-MAS, or call it Hamas. You will need to be very, very proactive. And I think as rheumatologists, we are fond of methylprednisolone more than a dexamethasone. I think I'll cover a part of it in my next lecture on steroids, but this is tailor-made for while I start pulsing 30 milligram per kg solumedrol for this kid. I am skeptical about what I'm seeing right now because
That was what we did. That was what we did. Opinions vary.
I actually used Dr. Priyankar's paper to sell methylprednisolone in dengue HLH because they seem to believe him more than the rheumatologist in Mumbai. I showed him that IIP ka paper, see, rheumatologists treat HLH and dengue differently. So like he said, Dexa versus Solumedrol, I think that methylpred works faster, gets out faster. So Dexa is a long-acting drug, longer half-life. In an emergency, give methylpred, 10 mg should be okay, if not 30. And then
We increased the dose the next day. We caught up with you. So post-IVG steroids, you can still see the day 2, the ferritin is still hovering in 1 lakh. The OTPs are still very high, and now you have worsening renal parameters. Kaushik, how will you manage this patient? And you have ARDS now. So this is, the child has gone into ARDS and AKI.
So intense and appropriate supportive care, that's very important. So mechanical ventilation obviously for this kind of ARDS, and obviously these patients will tend to get progressively fluid overloaded with acute kidney injury, so would require renal support therapy in the form of continuous renal replacement therapy, and also obviously immunomodulation, which needs to be escalated. And also we have extracorporeal cytokine removal facilities now in the form of Cytosorb or Oxiris.
Just 1 or 2
along
words
with
about
CRRT.
Cytosorb.
So
Because a lot of people will not be knowing about it.
Cytosorb is an extracorporeal cytokine removal filter which can be attached in series with a CRRT circuit. The CRRT machine is there, with the circuit in series we can attach Cytosorb. And one filter will last for around 12 to 18 hours, so it will help to remove the cytokines by the mechanism of adsorption. And there is another filter called Oxiris, which comes integrated with the CRRT circuit. And the advantage is that if you use Oxiris, the whole filter along with the circuit with an appropriate anticoagulation can last for 72 to 96 hours. So effectively, Oxiris becomes more cost effective. And Cytosorb, every 12 to 18 hours, we have to change. That is
So your patient is still not improving. Vijay, would you like to do something?
Right. So
you have given methylpred, you have started Cytosorb.
So I'll ask them if they have 2 lakh rupees. I believe one filter costs 1 lakh of rupees. The Cytosorb filter costs about
75,000 here.
So that becomes 1 lakh in Mumbai. And in 1 lakh rupees, I can arrange for 10 injections of anakinra. So this is the perfect situation where cost cutting may not be that clever because the only chance of survival, and we know that anakinra definitely has a short half-life, better safety margins, and I would strongly consider anakinra at this point while continuing what he's doing. The most important thing is to balance out. You don't want to be giving anakinra and removing it from the exchange or the CRRT, etc. So time it in such a way, and depending on the weight and the pocket, think of anakinra straight away.
So anakinra is what we give. Anakinra has to be remembered. It has a very short half-life. So you can give subcut anakinra. A lot of people will recommend. In fact, Professor Cron himself recommended subcut 6-hourly anakinra just in a recent conference. So, but in the background of a coagulopathy, 15,000 platelets, we would give IV anakinra. We give twice daily IV anakinra, and this is what happened. You can see that actually, I don't know what really made a difference, but a difference was made. So anakinra, methylprednisolone, Cytosorb, CRRT, so everything was done, and the child improved. So that is the bottom line. I will again skip this because we have just, I think, 1 minute. Yes. So anakinra is coming up in a big way. In fact, so is severe dengue a cytokine storm syndrome? I think after this session, everyone will agree from this, yes, severe dengue is a cytokine storm syndrome. So there are a lot of papers now, and I will just skip this. So I will come just to the 2022 EULAR ACR points, HLH mass, the initial, what do you think? So systemic hyperinflammation is an immunological continuum. The characteristic clinical and laboratory findings are individually non-specific, but when viewed collectively, it forms sort of an algorithm that we were talking about. And severe inflammation can be associated with hyperferritinemia. So I will again skip this. And treatment, what they have said, steroids, IVIG, or anakinra. So whatever you have. But anakinra again is coming up in a big way. So the final thoughts, CRS or CSS is present almost in all infections. But the manifestations may vary. The trick possibly is to think of CRS or CSS, identify that something is not actually going on, something normally is actually not going on, and intervene. So I think that is the most important thing, that timing. So the timely intervention, I think that is the most crucial. So think, diagnose, individualized, treat. And sometimes you need to hit hard, not only hit hard, hit fast, definitely, and hit often, as we did in the dengue patient, steroids, anakinra, CRRT, filter, so hit often. Thank you.
Thank you. Thank you for such a nice discussion. Now this panel is open for questions from the house.
Can I ask a very simple question from a lab? Have you asked your lab, do they do ESR, and what is the method? The conventional Western or the automatic method? Because you said they have stopped doing.
No, that was a joke. I said the pediatricians have stopped doing ESRs. Westergren.
That is what the problem is. All the present cell counters having automated ESR in a 20 seconds. So this ESR is not a sedimentation rate. It is an erythrocyte agglutination rate. It's information for all my clinical colleagues. Scenario of ESR is changing. It is no more a erythrocyte sedimentation rate, erythrocyte agglutination rate. That is what the automated machine gives because your report is in 20 seconds. So I need to calibrate the ESR with this. And I have done a good number of 1,000 cases. High ESRs are fine, but the low ESR in this automated system, it's not there. And usually the European community is all automated ESR. They don't do a manual, wait for an hour, go for a second hour. So they don't give you a report of millimeter per hour. They give only millimeters. Please check on your reports.
Okay, thank you, sir.
So I have a question. As a intensivist, I am working in pediatric intensive care. I would like to ask you that if a child is admitted in our setup who has fulfilled the criteria of HLH, before starting secondary HLH, before starting treatment, which one will be important, the clinical condition or the inflammatory markers? So in which one will you treat?
I think
with
both.
immunomodulator?
Both. So basically you're treating a patient ultimately. So the clinics as well as the marker should go hand in hand. I think Rajiv is dying, and this is the last question because we're running late.
Condition will have more weight. But investigations are important for monitoring, constant monitoring and follow-up, the trend of counts, the trend of your albumin and ferritin. So in other words, ferritin in more, I don't think just one ferritin, more ferritin means more serious patient. It does not. It may not always correlate with the clinical
everything
condition.
should be
The
taken
clinical
into
condition
account.
is important,
So everything.
but investigations for
Yes.
monitoring will.
So last question, Rajiv. Yes.
Not a question, just a comment that this is a very common scenario that we get. And like if you are involved with a PICU and if you unfortunately have a nephrology and a rheumatology, all working together, and anakinra is removed by CRRT. And this sort of a patient, we cannot do normal dialysis. So like future studies should be focusing on like whether we have to increase the dose of anakinra or something like that.
So if you remember what we did in this patient, so before the CRRT we were giving the anakinra. So anakinra itself has a very short half-life. So
yeah, but often like these children are so sick that you cannot even
I understand.
postpone the
So,
CRRT. So whether
Sir,
that dose can be...
anakinra would be removed by CRRT or CRRT plus cytosol?
No, no, CRRT
Only
also.
CRRT also.
CRRT can remove anakinra.
So actually, the anakinra in sepsis related HLH is 30% mortality benefit. Last 1 year back, one multicentric study has found in adult 30% mortality benefit, but in others not. But actually, these are plural things: polygenic disease, different infection, different comorbidity, and different outcome. We need to have some sort of not consensus. We have to club these patients in different domain and find out what are the patients, which are the response. So this is a more statistical things we need to work on, like a Monte Carlo simulation related things. So thereafter we can find these subsets. So this is a very complex thing.
Definitely.
And
definitely.
more to evolve.
Definitely. So during COVID, possibly because of the global emergency, people were together working. They came up with a lot of things, Arki. Thank you.
Okay, so we have come to the end of this session. Thank you, Dr. Priyankar Pal, moderator, and all the panelists for the wonderful discussion. Thank you.